Welcome to the deep dive. Today, we're zeroing in on a specific neurological condition, normal pressure hydrocephalus, NPH for short.
That's right.
Think of this as us taking some really dense revision notes and, pulling out the absolute must-know stuff, making it clear, high yield, whether you're learning this for the first time or just brushing up.
Exactly. Our mission here is to kind of cut through all the detail and give you the real core nuggets about NPH. Super useful for revision, getting up to speed for the wards, or honestly, if you're just curious about it.
Yeah, the source material we're working from is pretty comprehensive. Covers NPH from definition right through to complications. We're aiming to unpack all of that effectively for you.
And it's definitely a topic worth diving into. Why? Because NPH is one of the few potentially reversible causes of dementia. That's huge.
Absolutely huge. Recognizing it makes a real difference.
Precisely. Understanding the specifics is key.
Okay, so let's unpack this then. Starting right at the core, what actually is normal pressure hydrocephalus?
Well, fundamentally, it's a neurological condition. You get this buildup of cerebrospinal fluid, CSF, the fluid bathing your brain and spinal cord, and it collects inside the brain's ventricles, those fluid-filled spaces, causes them to get bigger, to enlarge.
But the name, normal pressure, that seems a bit odd if there's fluid buildup.
Yeah, it's a bit counterintuitive, isn't it? Despite the extra fluid in the enlarged ventricles, the average pressure of that CSF when you measure it typically stays within the normal range.
Okay, so how does that work?
It seems the main issue isn't that the brain is making too much fluid. It's more about reduced absorption. The fluid isn't draining away properly through these little structures called arachnoid villi. So volume goes up, but average pressure might not spike, sort of dynamically.
Got it. And the absolute key thing, the classic sign everyone learns.
Ah, yes, the triad. If you hear these three things together, NPH should be right at the top of your list. The mnemonic helps a lot. Wet, wacky, wobbly.
Wet, wacky, wobbly. Let's break that down.
Okay. Wet refers to urinary incontinence, problems with bladder control.
Right.
Wacky points towards the cognitive side, so dementia or cognitive impairment.
And wobbly.
That's the gait disturbance, difficulty walking, often quite distinctive.
And just to stress that point, again, it's a reversible cause of dementia. Accounts for maybe 6% of cases, which sounds small, but that's 6% you really don't want to miss.
Exactly. Now, technically, you can classify hydrocephalus in different ways, like communicating versus non-communicating. But for NPH, both the forms we usually talk about, idiopathic and symptomatic, are generally considered communicating hydrocephalus. It means the fluid can still flow between the ventricles. The problem is that absorption outside them typically hits people over 60. You see that ventricular dilation on scans. The underlying process is, well, complex, involves CSF dynamics, maybe some reduced blood flow, even a bit of inflammation.
So what actually causes it? You mentioned two forms.
Yeah, broadly two categories based on the cause. First, there's idiopathic NPH.
Idiopathic meaning no clear reason.
Exactly, no identifiable trigger. This is actually a more common one, maybe about half the cases, and mostly affects older adults. Just seems to develop.
Okay, and the second type?
That's symptomatic NPH, or secondary NPH. This happens because of something else, like a previous bleed around the brain, a subarachnoid haemorrhage, or infections like meningitis, maybe a significant head injury, sometimes even a brain tumor. These things can damage the pathways for CSF absorption. And unlike the idiopathic kind, this can affect people at any age, really, depending on when that initial event happened.
But interestingly, the source suggests both types, even with different origins, kind of end up looking similar in terms of outlook.
Yeah, that seems to be the case. According to this material, the shared problem is that fluid buildup mechanism.
So thinking about who's at higher risk, who should we be particularly aware of?
Well, the biggest factor, hands down, is just getting older, especially being over 60. That fits with the idiopathic form being common.
Makes sense. What else?
A history of things that might have messed with CSF flow before. So previous head injury is a big one, or any kind of brain surgery.
Right.
And definitely past infections or bleeding near the brain, meningitis, encephalitis, subarachnoid haemorrhage, anything that could cause scarring or inflammation around those absorption pathways.
And underlying structural things, like tumors.
Yeah, brain tumors or vascular malformations, anything that could physically obstruct the flow or absorption of CSF, they're also on the list of risk factors.
Okay, let's get into the mechanism a bit more. The pathophysiology. How does this actually unfold in the brain?
It starts with that core problem, impaired CSF dynamics. Specifically, the absorption isn't keeping up with production.
Right, the drainage is blocked or slowed down somehow.
Exactly. So the fluid starts to accumulate. Since it can't drain properly, it builds up in the ventricles, and they begin to stretch and enlarge, like inflating a balloon inside the brain almost.
And that stretching puts pressure on the brain tissue right next to the ventricles.
Precisely. That mechanical pressure and distortion on those adjacent brain structures, the nerve fibers for walking, the areas involved in bladder control, the cognitive networks, that's what leads directly to those wet, wacky, wobbly symptoms we see clinically.
Got it. Now, how common is NPH, actually? We mentioned it's often in older adults.
Yeah, the numbers suggest it's maybe more prevalent than some might think in that age group.
Like in the UK, the estimate is around 1 in 200 older adults.
That's one figure, yeah. Some specific studies, like one from Western Sweden, gave figures like 0.2% in the 70-79 age group, but jumping up to nearly 6%, 5.9% in people over 80. That's quite a leap.
Wow, yeah.
Of course, the number treated with surgery, with shunts, is lower, maybe 2 to 3 operations per 100,000 people each year. Gives you another angle on it.
And confirms what we said, typical onset around 70, affects men and women pretty equally. And that key figure, again, about 6% of all dementia cases. Worth remembering.
Definitely. Okay, let's really flesh out those clinical features. What does it look like? We keep saying wet, wacky, wobbly, but what does that mean day to day for a patient? Usually one symptom starts first.
And often it's the wobbly part, right? The walking changes.
Very often, yes. That's frequently the first thing people notice, the gait disturbance. And it's quite characteristic. It's usually described as slow, shuffling steps, often with a wide base, so feet further apart, trying to stay stable. It can resemble Parkinson's disease superficially, but crucially, you typically don't get the rigidity or the resting tremor you see in Parkinson's.
That's a key distinction.
Huge distinction. Sometimes patients describe feeling like their feet are stuck to the floor, these freezing episodes. It's sometimes called gait apraxia. Seems to be from pressure on those motor fibers running near the expanded ventricles.
Okay, then wet the bladder issues.
Yeah, the sphincter disturbance. This often starts subtly, maybe just increased urgency, needing to rush to the toilet or going more frequently. Then it can progress to actual urinary incontinence. Less commonly, bowel incontinence can occur too. This is thought to be due to the effect on the nerve pathways controlling these functions, particularly involving the cecal nerves.
And finally, wacky, the cognitive side, the dementia.
Right. In NPH, this often affects executive functions first. Things like planning, organizing thoughts, multitasking, problem solving. Patients might also seem apathetic, slowed down in their thinking. There's a term, bradophrenia. Memory problems occur too, but maybe disorientation is more about time, what day is it, than place, where am I, especially early on.
And does it progress quickly?
Generally, the cognitive decline in NPH is described as slower than in, say, Alzheimer's disease. It's thought to relate to distortion of brain structures near the ventricles that are part of the limbic system, important for memory and emotion.
It's really important to remember, though, that not everyone walks in with all 3 symptoms fully developed, right? Maybe only 60% have the full triad diagnosis.
Absolutely. Symptoms creep up gradually, usually over several months. And another key point, unlike hydrocephalus caused by really high pressure, you typically don't see papilledema, swelling of the optic nerve at the back of the eye in NPH. That's a crucial negative finding.
Any other symptoms to look out for?
Sometimes people report dizziness, but more like a sense of instability than true spinning vertigo. In more advanced cases, you might see some stiffness or spasticity in the legs, more freezing, and reflexes might become overly brisk, hyperreflexia. Examination might show subtle signs related to those motor pathways, the pyramidal tracts. But again, no papilledema is key. Interestingly, there might be an association with glaucoma, though.
Okay, this is where it gets super important clinically. The differential diagnosis. Why is NPH knowledge so critical here?
Because, as we've touched on, those core symptoms, the walking problems, the cognitive decline, they overlap massively with other much more common conditions in older adults.
Like Alzheimer's, Parkinson's.
Exactly. Alzheimer's, Parkinson's, vascular dementia, these are the big ones. But also things like frontotemporal dementia, multiple system atrophy. Lots of conditions can cause similar pictures.
So you have to think about NPH.
You absolutely must. Because if you miss NPH, you miss the chance to treat something potentially reversible. You might label someone with progressive dementia when actually they have a condition that could improve significantly with treatment. That's the whole point.
Okay, so if it looks like so many other things, how do doctors actually nail the diagnosis? What investigations are used?
It usually starts with brain imaging, an MRI or a CT scan.
They're looking for.
Enlarged ventricles. But, and this is important, the enlargement should look out of proportion to the amount of general brain shrinkage or sulcal atrophy you might expect for someone's age or compared to other dementias.
Right, not just age-related changes.
Precisely. There's even a specific pattern some look for called DESH that stands for disproportionately enlarged subarachnoid space hydrocephalus. It involves specific changes at the top and midline of the brain and is strongly associated with gait problems in NPH. Sometimes other tests like isotope cystoscopy are used to see how the CSF is flowing, but MRI-CT is primary.
And what about that TAP test you mentioned?
Ah, yes, the CSF tap test or lumbar puncture. This is really key. First, they measure the opening pressure, which, remember, should be normal or only slightly up in NPH.
Okay.
But the crucial part is after they drain off a decent amount of CSF, say 30-50 millilits, they then reassess the patient's symptoms, especially their walking and maybe cognitive function, shortly afterwards and maybe over the next day or so.
And if they improve?
If there's a noticeable, even temporary improvement, that's a very strong sign it is NPH, and it also predicts that the patient is likely to benefit from a shunt. So it's both diagnostic and predictive.
Makes sense. Are there other tests?
For tricky cases, yeah. Sometimes they might do continuous intraventricular pressure monitoring over 24 hours or so to get a better sense of pressure dynamics, or a lumbar infusion test where they infuse fluid into the spinal space and see how the pressure responds. If it shoots up abnormally, it suggests absorption is impaired.
So putting it all together, the diagnosis relies on having those clinical triad symptoms: CSF pressure that isn't sky high, and then either the characteristic imaging findings like DESH with gait issues, or seeing that improvement after a CSF tap test or drainage.
That's a pretty good summary of the diagnostic criteria, yeah.
Right. So you've got the diagnosis or at least a strong suspicion. What's the management? How do you treat NPH?
This is where NPH really differs from other dementias. The primary management is surgical.
Specifically putting in a shunt.
Exactly. The standard procedure is a ventriculoperitoneal shunt, a VP shunt. They insert a thin tube into one of the brain's ventricles, connect it to a valve system, usually placed under the scalp, and then run another tube under the skin down into the peritoneal cavity, the abdomen.
And the idea is just to drain off that excess fluid.
Precisely. To bypass the blocked absorption pathways and divert the CSF somewhere else where the body can just absorb it, like the lining of the abdomen. This reduces the volume in the ventricles and relieves the pressure on the brain tissue. There's an alternative, a ventriculoatrial shunt, draining to the heart, but VP is more common.
Are there any non-surgical options that work? Medications?
Well, the sources mention things like carbonic anhydrase inhibitors. Acetazolamide is one which can slightly reduce CSF production. Diuretics are also mentioned. However,
But they don't really work well.
the source material is quite clear. These have very limited success in NPH and are generally not advised as alternatives to surgery. Maybe, just maybe, as a temporary measure if someone is completely unfit for surgery, but that's about it. Repeated lumbar punctures also only offer temporary relief at best.
So the real take-home is VP shunting is the definitive therapy.
That's the main message for effective treatment, yes. And it's not just the surgery rehabilitation afterwards, especially physio to work on the gait and balance, is often really important to maximize the benefits. Plus, careful patient selection for who is most likely to benefit from the shunt is key, although predicting response isn't always straightforward.
What's the outlook then? If someone gets a shunt, what's the prognosis like?
This is potentially the really positive part of the NPH story. With treatment, many patients can see significant improvement.
Which symptoms tend to improve most?
Often the gait disturbance shows the best response, but cognition and bladder control can improve too. The outcome really depends on things like the patient's age, how severe the symptoms were beforehand, other medical problems, and just individual response to the shunt. But definitely, earlier diagnosis and treatment seem to lead to better results.
And the success rate is pretty high, isn't it? Something like 80–90% see improvement.
Yeah, those figures are often quoted for significant symptomatic improvement after shunting. And again, getting that shunt in early, maybe within 3 months or so of symptoms becoming really noticeable, seems to boost the chances of a good outcome.
But it's not always successful.
No, unfortunately not. The sources mentioned maybe 6% might have permanent problems or even die, though that's rare, and a significant minority, perhaps around 22%, might need further surgery later on if the shunt has problems.
Which brings us to complications. Surgery is never risk-free. What can go wrong with the shunt?
That's the main source of issues, the shunt itself or the surgery. Complications aren't uncommon. Maybe up to 10% of patients experience something.
Like what?
Most commonly, the shunt can malfunction, it can get blocked, or the valve might fail. That often needs revision surgery.
Infection is a risk too, I imagine.
Yes, shunt infection is a serious concern. Then there are issues with drainage. Sometimes it drains too much fluid, causing low-pressure headaches or even subdural hematomas, bleeding around the brain. Or it might underdrain, not relieving the symptoms enough.
Wow.
The catheter tubing can break or migrate. And then there are the general risks of any brain surgery, like bleeding, stroke, seizures, although these are less common.
So it really underscores that while shunting can be life-changing for NPH, it requires careful monitoring and management long-term to deal with potential complications.
Absolutely. Regular follow-up is crucial.
Okay, so wrapping this up, we've dived deep into normal pressure hydrocephalus. We've covered what it is, the causes, how it develops, who gets it, and crucially, that classic triad: wet, wacky, wobbly.
Right. We talked about distinguishing it from other conditions, how it's investigated, especially imaging and that key CSF tap test, and the main treatment, the VP shunt, plus the prognosis and potential complications.
So what's the big picture here? What does this all mean? I think this deep dive really hammers home how vital it is to spot that particular combination of symptoms, the walking difficulties, the cognitive changes, the bladder issues, because it could be NPH.
Yeah, something potentially treatable. Unlike so many other things that look similar in older people, it absolutely has to be on your radar in the differential diagnosis.
Which does make you wonder, doesn't it?
What's that?
How many people out there might have NPH, might have a potentially reversible cause for their symptoms,
Yeah.
but are perhaps misdiagnosed or just assumed to have something progressive like Alzheimer's if NPH isn't actively considered and investigated?
That is. Yeah, that's a really important question. A sobering thought, actually. Highlights why understanding this condition matters so much.
Absolutely. Well, we really hope this deep dive has helped solidify your understanding of NPH, giving you those key facts whether you're revising or just building your clinical knowledge.
And if you are revising, perhaps for the MSRA, or you just want more resources like this deep dive, remember to check out passthemsra.com.
Yep. And for loads of free, high-yield medical information, questions, and resources, definitely take a look at freemsra.com.
Thanks very much for joining us for this deep dive into NPH.
Keep learning.